I'm Dr. Arturo Loaiza Bonilla, a practicing medical oncologist and researcher, and the medical director of oncology research at Capitol Health Cancer Center, with offices in Pennsylvania and in New Jersey. During today's ASCO highlights, we had the opportunity to review the updates on colorectal cancer. The first study that we discussed was the Paradigm Phase 3 clinical trial. This clinical trial was aimed to assess the efficacy in a randomized setting between the use of FOLFOX6 plus panitumumab versus FOLFOX6 plus bevacizumab in patients in the first line, mostly focusing on left-sided and overall population of colon cancers. What this study showed is that it established superiority in terms of overall survival for patients with left-sided colon cancer and overall who had treatment with FOLFOX and panitumumab in first line. It also showed the potential increase in response rates and arterial resections following responses in patients with oligometastatic disease, particularly around those who had liver-only disease. So what this study is showing us is that amongst the many options that we have for the management of colon cancer, particularly in first line, in left-sided colon cancer, FOLFOX and panitumumab is a very good alternative that we can consider for our patients and may become one of the standard of care options for our patients in our daily practices. The second study that we analyzed was the Phase 2 IMPROVE trial, where we are analyzing the evidence for intermittent use of FOLFIRI panitumumab versus continuous use. And this is just reflecting our practices sometimes that we may decrease the intensity or the cycles of some patients, giving them a treatment-free interval and the potential efficacy and outcomes. So the data is still not mature for overall survival, but we know now that for patients overall, particularly those who has RAS and BRAF wild type, the use of intermittent FOLFIRI and panitumumab seems to be at least equally as beneficial, and there's a potential signal of less side effects and potential improved PFS. The other studies that we discussed as well was the incorporation of circulating tumor DNA in the adjuvant setting for colon cancer. So patients with stage 2 colon cancers who were treated after surgery, they analyzed the circulating tumor DNA at week 4 and week 7 and were randomized 2-to-1 to an arm where patients were treated if they had positive ctDNA regardless of clinical or pathological features, versus if it was negative, they just basically started surveillance. And the other arm was just basically the standard of care things we do in our practice based on high-risk features, and gave the patients chemotherapy based on that. So what we found is that the assessment based on ctDNA was non-inferior to what we do in our clinical practice. So this is an impactful result from the dynamic trial, and may also spare some patients from chemotherapy when they don't need it. And when they have ctDNA positive, it may impact positively for improving outcomes, at least in RFS, because we're treating those patients and in favor more in the combination with oxaliplatin-based treatment, but certainly something that we should definitely follow with more registries such as the COBRA, Circulate, and Circulate Prodigy. And last but not least, the late-breaking abstract from Sloan Kettering use of dostarlimab in locally advanced rectal cancers, where the first 14 patients assessed on this clinical trial who have MSI high features, either germline or through somatic testing, had a complete response in terms of clinical assessment, endoscopically, MRI, and PET avidity. And we are assessing this now as an opportunity to decrease the patients who may require TNT or may require any surgical or chemoradiation approach. So this highlights the importance of genomic testing, how we're changing the paradigm for our patients based on biomarkers, and how important it's going to be for the future so we can put those patients on different arms and categorizations based on genomics.